let's talk about optimal patient selection. How do you decide who is going to receive pertuzumab, who may receive pertuzumab in the adjuvant setting, et cetera?
So I think in the HER2 positive early stage disease, trying to decide how to treat is critical. I tend to treat most of my patients in the neoadjuvant setting for HER2 positive breast cancer in light of the Catherine data, which we'll get to. Occasionally patients present having already had surgery, and then we make decisions with the final pathology that we have available to us. In the neoadjuvant setting, I rely very heavily on our clinical exam and our breast radiology colleagues and breast MRI, ultrasound to really clearly define where we are. I do proceed with needle biopsies of axillary lymph nodes that look abnormal on imaging so that I can clearly define whether this is a person who has known lymph node positive breast cancer, which I think helps clarify things in terms of surgical approach and radiation options after neoadjuvant chemo to know if they had nodal involvement or not. For patients with T2 or larger tumors, or for patients with lymph node positive breast cancer, I tend to use TCHP, Taxotere, carboplatin, Herceptin, Perjeta, using that dual HER2 approach. For patients with T1N0 breast cancer, I tend to use paclitaxel trastuzumab, which we've seen great long-term outcomes with less toxicity than we would get with dual chemo, dual HER2 targeted therapy. And honestly, I will even do that in a neoadjuvant approach as well. But I think that how to optimally sequence and identify T1N0 breast cancers is an area of controversy right now in our field, and probably in light of the Catherine data, a group of patients that we need a little bit better, better long-term data on and how to stratify them. What about you, Dr. Hamilton?
Yeah, absolutely. I think clinically I practice very similar to that. We keep alluding to Catherine, and I promise the audience that we'll eventually get to that. But I think that's an important point, is that you know, we don't have to feel like we have to give, you know, a very aggressive regimen up front to somebody that we actually think is low risk. You know, to be eligible for adjuvant TDM1 per the Catherine trial, you really just had to have not had a pathologic complete response to whatever therapy you were given in the neoadjuvant setting. So I agree, for older patients or for patients that have very small tumors, I frequently give taxane trastuzumab because I think that that's maybe all that they need. If somebody does not have a pathologic complete response or ends up with more disease at the time of surgery, et cetera, you're certainly entitled and able under that label to go back and give adjuvant TDM1 in that space.
Something neither of us have mentioned yet is that really the hormone receptor status does not factor into my decision making here. I mean, whether somebody is a estrogen, progesterone receptor negative patient or a hormone receptor expressing patient, in that chemotherapy HER2 antibody decision making, that is not a part of my decision. Obviously, somebody who's expressing hormone receptors, then later on we add in endocrine therapy, but that doesn't shape what chemotherapy or HER2 combo I choose.
Absolutely, you're completely right. Now, it does affect what pathologic complete response rate you're probably anticipating. We know that the patients that also have hormone receptor positive status tend to have lower PCR rates, but you know, across multiple trials, whether it's pertuzumab or TDM1, you know, TCHP versus TCH, the benefit of those, you know, is not less for ER positive patients.